Real news for Americans 50 plus. This is Emeritus News Channel.
Good afternoon, everyone. What we have today is essentially more virus, more vaccine, and more treatment. Disease continues to be widespread and is currently widespread in 48 states. We're seeing some states decrease, particularly in the southeast of the U.S., but we don't know whether that's a decrease before an additional wave. It's only the end of October, and flu season lasts until May. In the past 2 months, we've seen more hospitalizations in people under the age of 65 than in most entire flu seasons. So we know that there's been a lot of disease from influenza, from H1N1, and virtually all of the influenza we're seeing is still H1N1. Genetically, the virus has not changed. It's still closely matched with vaccine. We have not seen mutations that would suggest that it would become more deadly. And some of our recent survey data helps us understand what people are doing in response to the in response to the virus. One of the things that we've been surprised to see is that even among people who have an underlying condition, such as asthma or heart disease or lung disease, only half sought care for influenza-like illness. Only half went to their provider. This emphasizes that whether or not vaccine is present and whether or not people recognize that they have an underlying condition, people with underlying conditions who have fever and cough should see their provider promptly. Children are a particularly high priority for prevention and for treatment. This is a younger people's flu. In a usual flu season, 90% of the deaths are among people over the age of 65. In H1N1, 90% of the deaths are in people under the age of 65. Up till now, there have been 114 laboratory-confirmed deaths among children. More than two-thirds of those have been children with underlying conditions. In terms of the numbers of cases, hospitalizations, and deaths, our focus is to prevent cases as effectively as possible and to encourage treatment. Counting cases, particularly the numbers of people who had influenza-like illness, is not something that's likely to be productive or accurate. We know that there have been many, many millions of cases. In terms of hospitalizations and deaths, we can provide information, and we do on our website each year, of the number of confirmed, laboratory-confirmed hospitalizations and deaths. We know that that's an underestimate of the total, because there are people who don't get reported, or laboratories that don't test, or laboratory tests that are falsely negative. And over the coming weeks, we hope to be able to give you the best available estimate of the number of hospitalizations and deaths to date. The number that you're familiar with of 36,000 deaths per year from influenza in a normal flu year is based on estimates, based on the best available scientific data of the burden of influenza. And we will, having learned as much as we can from the pattern of H1N1, particularly in the communities where we have very intensive monitoring of hospitals and other sites of care, be able to estimate how many cases there are likely to have been, or a range, or an at least number. H1N1 vaccine supply is increasing steadily. There's not enough for all providers or people who would want it, and this continues to be frustrating, but the gap between supply and demand is closing. Last week, we had 16.1 million doses available as of Friday morning, 5 a.m. for shipment. As of today, we have 26.6 million doses available for shipment. That's an increase of 10.5 million doses in that 7-day period. With that vaccination, with that increase in vaccine availability, we're seeing more schools doing vaccine clinics. We're seeing more healthcare workers getting vaccinated. More people at high risk are being vaccinated. More providers are getting the vaccine. But it's still not nearly as widespreadly as available as we'd like. Also, we're seeing really very strong demand for seasonal flu vaccination. And I'm sure that all of the media attention to influenza is driving that. But we are not seeing any spread of seasonal influenza yet, but there's no reason to think that we won't have a flu season this year with other strains of flu. Only time will tell. So we do continue to recommend seasonal flu vaccine, but we recognize that of the 89 million doses that have already been distributed by the manufacturers, the overwhelming majority has already been given. Manufacturers report that they'll be providing additional vaccine in November, December, so additional vaccine should become available. And the seasonal vaccine program is not run in the same way that the H1N1 vaccine program is run. In the seasonal vaccine program, it's the manufacturers selling directly to providers, and providers who order more may be able to get more. But there's right now not enough seasonal flu vaccine for all who would want to receive it. We continue to do everything that we can to reduce the impact of H1N1 influenza. One of the issues that's arisen is a shortage or spot shortage in some areas of the liquid form of Tamiflu. On October 1, we released 300,000 courses from the Strategic National Stockpile. We are now releasing an additional 234,000 courses of liquid Tamiflu from the Strategic National Stockpile. That is the entire supply from the SNS. We held back some portion before because in early October it wasn't clear whether some parts of the country might need more than others, and we kept it back for that purpose. It's now clear that with disease throughout the country, it makes sense to release what we have and to get more from manufacturers as soon as they can provide it. In addition to the liquid Tamiflu, we've worked with many of the national chains which are willing to compound to make the syrup from the adult Tamiflu, something that is safe for a pharmacist to do. Please don't try this at home. This is something that should be done by a professional pharmacist. And this is something that the pharmacy can do by taking adult Tamiflu capsules and carefully measuring it, putting it into a syrup that's palatable for children. And with this, it should be possible, sometimes with more effort than we would have liked, but should be possible for people who want to get Tamiflu to get it, who need to get Tamiflu to get it, and we're appreciative of the cooperation of the pharmacy chains in that effort. When we release from the stockpile, it's done on a population basis to all parts of the United States and territories. We're also working hard to improve vaccination efforts. And I want to take a moment just to reiterate some of the basic information, nothing new, but we continue to hear that there's confusion about who should get vaccine and when. We have left for each state and jurisdiction to have some flexibility within the priority groups if they want to sub-prioritize, but the overall priority groups remain as shown on this slide. 5 priority groups, and the slide outlines which of them, there we go, which of them can be used for, can receive which types of vaccine. Pregnant women at this point are only recommended to receive the injectable vaccine. Caregivers of infants under the age of 6 months can receive either the intranasal spray or the injection, unless, of course, they have an underlying condition or are pregnant. Children and young adults aged 6 months to 24 years of age can receive either the intranasal spray or the injection, unless, of course, they have an underlying condition or are pregnant. People aged 25 to 64 with an underlying medical condition should receive the injection. And healthcare or emergency medical service workers can receive either the spray or the injection. Of course, again, spray only if they don't have an underlying condition and are not pregnant. These are the 5 priority groups. There are some places that have sub-prioritized within that, and that's up to jurisdictions. That may depend on local supply and availability. The availability of large amounts, relatively speaking, of the intranasal spray, which is most easily used for healthcare workers and for school children, is facilitating work in that area. There is a little bit of an urban legend that healthcare workers shouldn't get intranasal spray. It's an attenuated virus that is cold adapted, so it can't cause a continuous chain of infection. It does not present a risk to patients. In contrast, an unvaccinated healthcare worker does present a risk to patients. So we encourage healthcare workers to get vaccinated.